Thanks everyone for joining us tonight. We'll be discussing male urinary incontinence. My name is Robert Goldfarb. I am a physician at Chesapeake Urology. This is a little bit about me. I came to Chesapeake Urology about 3 years ago after doing a fellowship in New York in male reconstructive urology. These are some of the specialties that I treat, or some of the conditions that I treat. Throughout tonight's webinar, feel free to send any questions, and we'll make sure at the end to have ample time for Q&A. So why don't we jump right in? What is urinary incontinence? Well, basically the definition involves the involuntary loss of urine. Various different subtypes of urinary incontinence. One of them is urge incontinence, which is typically leakage of urine that occurs with the strong urge to urinate. So it's a sudden urge that people will get, and it's usually the incontinence that is associated with the overactive bladder, and oftentimes patients will describe sort of that feeling that they need to rush to the bathroom with some leakage occurring sort of on the way. The other main type of incontinence is stress incontinence, which is what we'll be talking about for the majority of tonight's discussion. And that's incontinence that typically occurs with certain activities such as coughing, laughing, bending, sneezing, anything that involves an increase in abdominal pressure, and usually there's leakage associated with that activity. Other types of incontinence are overflow incontinence. So if you imagine sort of plugging in a drain and keeping the faucet turned on and leakage sort of comes over the top, that's typically associated with conditions that cause the bladder to overfill with urine and then leakage subsequently ensues. And then there's this other general category of mixed incontinence, which sort of is all-encompassing and can include different factors of each. But tonight we're going to focus primarily on male stress incontinence, which is the most common type of incontinence that men will experience. A little bit of physiology here and some anatomy, if you see on the right side, that's generally the male urinary tract. And in men, the urinary sphincter, which is what is primarily responsible for maintaining our continence, is a muscle that's located basically between the prostate and the urethra. And so this sphincter muscle surrounds the urethra, and when it contracts, there's no urine that is able to leak out. So many men will sort of know this muscle in the sense that they're trying to stop their urinary stream and then sort of resume it at a normal time. And when this muscle gets damaged, there's subsequent leakage that can ensue. And this is all based on the relative amount of urine that's in the bladder and then the type of activity that you're doing. So when that sphincter muscle is damaged by certain conditions such as prostate cancer surgery, which is the most common condition that we see stress incontinence occurring in, there will be leakage of urine that occurs with various activities that increase abdominal pressure. These are some of the other conditions in which men can have incontinence. Other than a radical prostatectomy, you can have it from a transurethral resection of a prostate or a Roter-Rooter type procedure. Certain conditions like diabetes and other neurologic conditions like MS or Parkinson's can cause incontinence. You can have incontinence that occurs after a stroke or other head injury. Pelvic trauma is another big source of incontinence, and then there's some certain congenital disorders that can lead to this. But tonight I really want to focus a little bit on post-prostatectomy incontinence, because this is, we see quite a bit, especially with the number of men that are diagnosed and treated for prostate cancer in the United States, which is about 5 million. This tends to be the most common occurrence. After a prostatectomy, and if you see the slide there, that's sort of showing you a little bit about what the anatomy looks like before a prostatectomy. And then after a prostatectomy, after the prostate is removed, the bladder is basically reattached to that part of the urethra, and the sphincter muscle is sitting right below the prostate. And so oftentimes it is sort of in the line of fire and can be injured during the prostatectomy. You know, these are all based on sort of where the prostate cancer is and how the surgery is done, but there is generally some degree of injury that occurs after a prostatectomy. And so almost every man that's had a prostatectomy immediately following the removal of their catheter will have stress incontinence, and this is a very normal occurrence. And in fact, it takes about 3 to 6 months before men actually will regain their continence. And thankfully, about 90% of guys that have a prostatectomy will be pad-free at about 3 to 6 months. And so the way in which that occurs is by sort of training those pelvic floor muscles and training that sphincter muscle to become stronger. Usually these are exercises that we teach men, you know, a few weeks prior to their prostatectomy so that they're able to sort of identify those muscle groups. And these are, you know, Kegel exercises. So if you imagine trying to start and stop your urinary stream, and once you've identified those muscles, those are the ones that you're going to be engaging to sort of strengthen the pelvic floor and urinary sphincter. And then after your prostatectomy, when you're having this incontinence, you sort of learn how to engage those muscles and strengthen them to regain your continence. Now, unfortunately, about 10% of people after a prostatectomy will have persistent incontinence. And this is incontinence that generally persists, following 6 to 12 months after their prostate cancer surgery. In general, incontinence that occurs after 12 months will not able to be improved by just doing physical therapy or more Kegel exercises. This next slide is sort of the main reason that everyone is here tonight is to discuss why should we worry about this and why should we treat it. A lot of guys have had prostatectomies and, they're very focused on the fact that their PSA is undetectable and that they're cancer-free. And many men sort of become prostate cancer survivors, 2-3 years after, but are still left with this bothersome incontinence. The main reason that we're here tonight is to sort of talk about some of the challenges associated with that and why you should worry about fixing this as opposed to just being happy that the prostate cancer has been cured. And so, this is a recent study that was done that actually asked men with stress urinary incontinence sort of what bothers them the most about it. So this is perhaps the most important slide, and I think it goes through a lot of different things with regards to some of the negative impacts that incontinence can have on men. And I think that this is an area of urology that traditionally has not gotten as much attention, particularly when looking at certain things with regards to cancer survivorship. So a lot of men, are able to feel comfortable discussing with their peers, with their loved ones about such issues as erectile dysfunction and other problems that occur after, prostate cancer surgery. Incontinence, though, tends to be one that is a little bit underaddressed. And this leads to a lot of undertreatment. So this is a problem that is sort of still flying under the radar. And yet men that report it actually are very bothered by the symptom. It tends to affect them in numerous different ways. Oftentimes they find that they're sort of isolating themselves socially because they're worried about the smell. They're worried about, having uncontrolled leakage that their peers or friends will see. Other things that it will do is sort of isolate them from activities that they once enjoyed, particularly activities like, exercise, golf, tennis, or other things, primarily because those activities will worsen the incontinence. It can also cause problems, with personal relationships, primarily with regards to leakage that occurs during encounters with a loved one. And so they can be very isolating. Men will also sort of feel a little bit as though the problem is not being adequately addressed just because there is a limited understanding and feeling that there's little that they can do about this. And so this is a survey that we did that sort of looked at asking men specifically what bothers them about incontinence. And you can see the variety of different answers that you get. In general, most men will report that the smell and the irritation to their skin are the most bothersome issues regarding this. And overall, there is a reduced quality of life that people have when they're suffering from incontinence, particularly, years after their prostatectomy. The first step in deciding on a treatment is recognizing that there is a problem. And this is a really good website. And you can see it's a good title of his story, The Long, Wet Road Back to Normal. You can find this online. And this is basically one man's journey about how he went through prostate cancer surgery and ultimately found way back to getting through his incontinence. This is another great website, fixincontinence.com. There's various different stories or vignettes that real patients have provided that go through different aspects of the incontinence and the sort of impact that it had on their lives overall and how they fixed it. So let's go through some of the different treatment options that there are for incontinence. This sort of starts off by the least invasive to some of the more invasive, which we'll get to towards the end. There's lifestyle and behavioral modifications. So what are the behavioral modifications? Well, those are pretty simple. Stop drinking water and you won't have incontinence. What goes in must come out. And so if you minimize what you take in, it'll minimize sort of what comes out. Taking planned restroom breaks is actually a really good thing, particularly for men that are early on, in their post-prostate cancer recovery, just in order to sort of prevent incontinence from happening at inopportune times. So before sexual activity, before exercise, before going over a friend's house. Sort of noticing, I would say, activities that increase intra-abdominal pressure. So, you obviously can't recognize that a sneeze is coming on and coughing is pretty much illegal these days, but other activities such as bending down, sort of getting out of the car, knowing that these activities that are going to sort of spur leakage and being able to sort of prevent against them. I should say right off the bat, there are some medications that have been used to help guys with stress urinary incontinence, but none of these are FDA approved, and generally they work by helping to relax the bladder, so minimizing the bladder from functioning so that it stores more as opposed to actually treating the incontinence. So it's a little bit of smoke and mirrors with that, but there are not really any good medications that are FDA approved or effective for the treatment of this condition. So the other one is pelvic floor physical therapy. These are Kegel exercises or going to PT and actually learning biofeedback. This is very important for men prior to any prostate cancer surgery that's planned, and it's really important in the initial recovery. However, it's not a recommended treatment once you've gone beyond 6 to 12 months after the prostatectomy. There's been ample studies that have shown that it typically is ineffective at this point. And it really becomes difficult, particularly in men who have had additional radiation therapy after prostate cancer. These pelvic floor physical therapy or pelvic floor activities, they tend to be ineffective in these settings. The other treatments, we sort of lump together as absorbent pads. This is, I think, a nice slide kind of showing you the different types of pads or Depends or diapers. Basically shows you kind of a little bit about the varying degrees to which they can control incontinence. And I think anyone that's using these, particularly long-term, should be asking themselves, if this is a satisfactory solution. Is this sort of how you envisioned your life after prostate cancer surgery? In the short-term setting, it might be reasonable, but is this really long-term the goals that you have? What are the side effects or inconveniences of using these? The smell, the odor, not to mention the cost. Typically men with mild or moderate to severe incontinence will spend up to $7,000 a year just on absorbent pads. The sort of next step upward is from absorbent pads is clamps, and I don't know, that doesn't look too comfortable. And most men are bothered by using these kinds of clamps. They tend to be painful. They tend to be bulky and sort of irritating. One underneath is a condom or a Texas catheter, which, requires actually attaching it to a bag. And so these are long-term. Sustainability is not great with these. So getting a little bit into some of the surgical or more definitive treatment options, these I would say are not necessarily in the short term, but men who have actually said that some of these other treatments are not satisfactory for them long term and are ready to take the next step in addressing this problem for good. We talk about male slings and the artificial urinary sphincter. And so what is the male sling? The male sling is basically designed to better support the urethra and better control the sphincter muscle. It's a small piece of mesh, which you can see underneath there. It's a small incision that's made underneath between the scrotum and the anus where the urethra is, and it's sort of attached to the urethra, and then it's brought out through two poke holes kind of near the thighs, and then it's tightened to help reposition it. Just a note here, a lot of people might have questions about mesh. This is a different type of mesh than we talk about with female incontinence surgery. And so these meshes are not the ones that are implicated in various commercials that you might see about mesh extrusion or mesh erosion. And so this is a pictorial which shows sort of how the male sling works. And basically what it is it attaches to the part of the urethra and it helps to reposition it to a place where it's better able to function. So in men that have mild to moderate incontinence, so 1 to 2 pads a day, particularly where they're able to actually contract their urinary sphincter muscle, a sling is a very reasonable option in terms of helping to manage their incontinence. This is performed as an outpatient procedure. It usually takes about 60 minutes or so. You're able to go home the same day. Oftentimes, a catheter is left in place for about 24 to 48 hours. In terms of restrictions or limitations after surgery for recovery, in general, it's avoiding excessive exertion or heavy lifting for about a week or two. Most men usually don't report too much in the way of pain or discomfort after it, and it's very effective for men with mild to moderate incontinence. So about 2 pads per day. The next one is the artificial urinary sphincter, and this is actually a picture from the initial design. It hasn't changed much in about 40 years, which is when it was first introduced back in, I think, 1972. And this basically is exactly what it sounds like. It's aimed at replicating the function of the normal external sphincter, which, in most men that have had prostate cancer surgery and severe incontinence is deficient. And so it can treat all sort of varying degrees of incontinence, including severe incontinence, particularly in men who have had radiotherapy, part of their treatment. And it's basically composed of 3 different parts. One of them is the cuff, which goes around the urethra. There's a small pressure regulating balloon, and then a small pump that goes in the scrotum. All of this is concealed within the body, and you would never see it. So this is a animation with regards to how the male urinary sphincter works. And so this is what it would look like from the outside, and then you're kind of seeing the 3D or the X-ray vision here. Once you activate it by squeezing that little button, that releases the pressure that's in the cuff. Then you go to the bathroom. After the button is pressed, then the cuff will automatically reinflate after about 90 seconds. So it will then restore its grip on the urethra to prevent any further leakage. Like I was saying, the artificial urinary sphincter has been around for about 40 years, and I think one of the things that's nice about it is it hasn't changed much in this time. It's basically the same design that was introduced back in the 70s. Like I said, it can fix all degrees of incontinence, including incontinence that occurs after radiation therapy following prostate cancer. I think that this is probably the most telling, is that if you ask guys, and when we talk about these types of procedures or surgeries, unlike prostate cancer surgery where the outcome that you're looking for is whether or not the cancer was cured, this is a quality of life type of surgery. So we look at patient satisfaction to sort of gauge the success. And if you think about something like a hip replacement, which a lot of people know someone that's had this, only about 75% of patients that have had a hip replacement actually are satisfied that they had it. The artificial urinary sphincter has over 90% patient satisfaction. And so it's one of the highest satisfaction surgeries that, is done. And so I think that that's very telling about how men feel about it. And I would say that when we do this for patients, they are oftentimes more willing to discuss their experience with other men that have had this. And there's a very wide network we have of patients that have had this procedure successfully done who actually are willing to, would like to participate in talking with other men about this condition and about what the procedure was like in their experience. And so we do have patients that, have, volunteered to actually be advocates and to talk to other patients that might be considering this. Similar to the sling, this is also an outpatient procedure. It takes about 60 to 90 minutes. Usually a catheter is in for about 24 hours. You go home, the next day you come back in, the catheter comes out. Again, a small incision that's between the scrotum and the anus. There's also a small incision that's right where the pump goes, about this big. In terms of what men will say with regards to their pain after surgery, I would say that generally people are taking pain medications for maybe 24 to 48 hours. There are very few restrictions that we have after the procedure. Obviously no heavy lifting or anything like that for about a week or so. But in general, most men are able to resume getting back to normal life pretty shortly after the procedure. These are some of the conditions where we don't indicate it is in men that have concurrent urethral strictures or contractures of the bladder neck. The other requisite is that you have to have, the manual dexterity to be able to operate the pump, the ability to remember to use it. Patients that have dementia or, severe Parkinson's might not be great candidates. In terms of sort of risks, I think that that's something that more of an individualized discussion, obviously. But so most of these devices have pretty good lifespans. If you look at the 5-year or at 5 years, over 75% of them are still in. When you get to about 10 years, there is about a 50% revision rate. And usually in that situation, we're oftentimes swapping out one device for another device in order to keep men dry. These are some decision-making tools. And so if there's a website you can go to actually that's called the tiny.cc/MSIGS. And once that you go to that website, there's a few questions that you'll be asked. One of them is with regards to whether or not you've had radiation therapy. The other is with regards to how many pads a day you're using. And that will sort of give you a score as to whether or not a sling or a sphincter is going to be which of those will be most likely to maintain your continence. And so I would welcome anyone to go to that website if they're having any other questions with regards to what might be right for them. But this is more of an individualized discussion. So oftentimes patients will come into the office, we'll assess the incontinence there. We'll often do a cystoscopy to make sure that there aren't any of these concurrent conditions. And then we'll talk about it a little bit more in terms of the specific risks and other nuances of the surgery. Hopefully this was a good overview of male urinary incontinence. This can be a really difficult problem to treat. And there's a lot of individualized discussions, and treatment plans that we'll be able to make. And we're here to sort of help you with any of these issues. And obviously everyone is unique and different with regards to the degree of incontinence they have and their, individual situation. We're here to support you in those ways and try to get you dry at the end of the day. At this time, I'd welcome anyone to ask any specific questions that they might have.
So in general, when I was talking a little bit about the sling, it's primarily useful to sort of think of it with regards to the severity of leakage and sort of the other conditions that you may have, other health conditions. In general, for a sling, there's very few that would be exclusive to sort of undergoing this procedure. In general, the biggest thing has to do with sort of the degree of incontinence, as well as, the type of treatment that you had that led to the incontinence or leakage. So if, it was prostate cancer surgery and then radiation, slings tend to not be as effective. Diabetes is not a reason that we would exclude anyone from having a sling. Other issues like high blood pressure, high cholesterol, sort of heart disease, those sort of things wouldn't necessarily impact, the effectiveness of the sling. Those would just be risk factors for surgery in general, but they wouldn't be exclusive to any one of these treatments at all.
Are there no prescription medications at all that work on male incontinence?
In general, if you're talking about, stress incontinence, which is primarily what we're talking about today, there aren't. You certainly will see men get prescribed certain medications for sort of not necessarily treating the specific cause of their leakage, but more so to help maintain or relax their bladder and prevent their bladder from contracting. So if you try to basically increase how much your bladder can hold and cause your bladder to relax more, sort of by virtue of that, some people think that might help to relax or prevent them from having more leakage. But in reality, the medications that are often prescribed are similar medications to people that just have urinary urgency, so they're bladder relaxant medicines. And so they don't necessarily, they're not really effective for the specific treatment of, leakage when you cough, laugh, sneeze, or something like getting out of the car, swinging a golf club, or playing tennis. They're just going to sort of try to relax your bladder more. And so while we sort of sometimes use them in these situations, they're not as effective and they're not really indicated. And long-term, they tend to they're not really tolerated long-term, and they're not effective long-term, really.
So does that include Myrbetriq?
Yeah, so Myrbetriq is a similar medicine. Myrbetriq, Vesicare, Tovias, all these medicines that are sort of more indicated in people that have some urinary urgency. It's interesting just because the sort of urinary symptoms that you may have after a prostatectomy, pelvic trauma, or anything that's sort of leading to male incontinence, you can have some sort of irritative urinary symptoms, so urgency or frequency, and still have leakage when you cough, laugh, or sneeze. There is somewhat of a use of these medications to help balance the bladder and to prevent it from contracting. But in terms of incontinence that's associated with injury to the sphincter muscle, which is, primarily what we see with pelvic trauma, post-prostatectomy, injury from radiation, certain neurologic conditions like Parkinson's, Myrbetriq isn't going to help to restore that sphincter function. That's skeletal muscle that's sort of been damaged, which is causing the inability to contract, which causes leakage every time you sort of increase pressure in your abdomen. And so the Myrbetriq isn't going to help with that. It's primarily going to help with urgency or sort of frequency type symptoms, which can sort of coexist, but not necessarily are going to be the main cause of the incontinence.
If a person has never had anything done with their incontinence after prostate surgery, what is the process for going forward with some type of treatment?
That's a long question. In general, before anyone has a prostatectomy, usually they'll meet with their surgeon and sort of prior to surgery, sort of go through basic pelvic floor muscle exercises or Kegels to sort of get a feel for what it's like to sort of contract those muscles and to activate the pelvic floor and external sphincter muscles so that you can sort of train it and strengthen it before the surgery. It's very difficult to do it afterwards, so we try to teach guys how to do it before they've had their prostate cancer procedure. Generally, after their catheter gets removed, there is more of a fluid incontinence, and guys will sort of definitely be using pads. They'll definitely have some degree of heavy leakage, and that's really when you start to use those Kegels. And most men, by about 3 to 6 months, will sort of have regained their continence or maybe be wearing 1 or 2 pads a day, and there's not going to have significant leakage. Once you've sort of gone beyond the 6-month mark, if you're still going through multiple pads a day, the likelihood of you getting dry from just doing pelvic floor or strength training exercises is very low. And this is particularly true for men who have had like adjuvant or external beam radiation after their prostate cancer surgery because of positive margins or other reasons. It tends to sort of suspend their process of regaining their continence and doing strength training exercises or Kegels because they now are undergoing radiation, which sort of freezes the sphincter muscle in place and prevents them from sort of reactivating it in the future. And so that's a really tough problem to deal with. Once you sort of have gotten beyond a year, going back to the gym, so to speak, and trying to, bulk up on the Kegels is a lot of guys try to do it, and the studies show time and time it's going to be of limited utility to getting you ultimately dry. This is when we start to talk about things like protective pads, diapers, depends, clamps, and then ultimately for men that sort of want to fix the problem or correct it in a more definitive way, slings and sphincters.
Does the sling completely resolve incontinence?
No, that's a short way, I guess. It's very individualized who responds to a sling. Sort of the ideal patient would be someone that's, recovered from their prostatectomy and maybe has 1 to 2 pads a day of incontinence, but, is able to control some urination, is able to sort of, activate that sphincter muscle. So we sort of ask them, in the morning when you urinate, if your bladder's oftentimes full at that point, are you able to sort of stop the stream or slow it and then sort of relax it again? So are you able to sort of contract that sphincter voluntarily? And if so, and you're only leaking maybe 1 to 2 pads a day, then a sling can be very effective and actually can get you, to being completely dry after a procedure. Other forms of incontinence, in particular, the severity of it, if there's difficulty controlling the sphincter voluntarily, so you can't really stop the stream, basically once you stand up, everything just kind of comes out. Or if you cough, sort of same deal, or you've had radiation therapy on top of that, then it's going to be difficult for a sling in and of itself to get you completely dry.
What about urgency all night? This person says they have to urinate every hour and a half throughout the night. What type of treatment would be best for this?
I guess just taking that symptom alone, I would call the office. We would talk about it more, but that's a tough question, I guess, just in the sense that other factors I would say that are going to be influencing, that if you're just having urgency, that's just a symptom or a problem with how your bladder stores urine, with regards to how it empties urine and whether or not there's leakage of urine involuntarily, particularly at nighttime, there can be factors that might be associated with what you're drinking or taking in. And then frequency of going every hour and a half, that's more likely a problem with maybe how the bladder is storing urine. But, I guess I would need a little bit more information that's sort of relevant to, I guess, better answer that.
This prostate cancer patient has had radiation but not surgery, and he wonders what are the implications from that on incontinence.
So a lot of the times, if radiation alone has been used, typically the type of leakage that men will have is more of the urge variety. And so that's typically leakage that occurs, with the association of a sudden urge to go to the bathroom. And for that type of leakage, some of the medications that we talked about previously, like Myrbetriq, those might be more useful because the sphincter muscle in those cases is oftentimes intact still. And really what's happening is not necessarily an injury to the sphincter mechanism, but more so a change in how the bladder is storing urine. The radiation that's delivered to the prostate ideally should be just delivered to the prostate, but there is some scatter effect, and more of that scatter effect after radiation, primarily, for radiation that's performed as the sole treatment of prostate cancer or combined with brachytherapy seeds, that tends to sort of cause more issues to the bladder itself. And so some of the sort of side effects or long-term complications of radiation therapy, it can be unique in that they sort of can change sort of the bladder and cause more of a urinary dysfunction or voiding dysfunction. There may be some inclusion of incontinence, but it's usually urge associated. I would be sort of somewhat suspicious of just pure stress incontinence after something like this. There are solutions, I would say, for all forms of incontinence. It just kind of varies. And tonight we were just sort of trying to take care or tackle the pure forms of stress and urge, I guess, and discuss those. But there's overlap.
If you try the sling and it is not effective, can you then go on to have an artificial sphincter surgery?
Yes. Yeah. In fact, that's very common. I would say a common scenario that we see is that there's persistent incontinence or persistent leakage after a sling. Yeah, it's very reasonable. And some people actually sort of choose having a sling by virtue of the fact that if it doesn't work, they can always go to a sphincter. It's not sort of necessarily the ideal way that I counsel patients, but it certainly is. It's feasible to do, and it's very safe and effective. Oftentimes we don't even have to dislodge the sling. You could just leave it right in place. There's enough sort of the urethra that we're able to place the cuff of the sphincter to where a lot of the times you can just leave the sling as it is, and then you can get the guy dry by putting a new cuff around in an artificial urinary sphincter. So yeah.
Are there any dietary supplements or vitamins that can help with incontinence?
Unfortunately, there's not anything that's going to necessarily address that directly. There's no vitamins or supplements that I know of that's primarily going to help with that problem in and of itself. This is a problem with muscle, and sort of how the muscle functions and damage to muscle. While we do talk about some of these conservative treatments and sort of behavioral modifications, if you think about it even from the perspective of Kegel exercises, which is sort of the mainstay or the starting point of treatment, a lot of the things that we're talking about, they do require sort of, if you can't get the muscles to sort of strengthen on its own or it's been damaged, there's not pills or anything like that we can do to sort of restore the muscle function or the nerves that innervate the muscle. So it does become sort of a surgical management in general in order to get the best outcomes, in order to get you completely dry. Some vitamins and supplements can certainly help with bladder health and that kind of stuff, but it's not going to get you from wearing 3 pads a day to dry.
As a patient, whom should I go to for advanced information? My urologist, my radiation person, or another expert?
I think you could start with any one of those people. Chesapeake is a great organization because it's a wide network of doctors, and we all sort of communicate with one another. And if you have one doctor that's taking care of your prostate cancer or radiation oncologist, and you certainly bring this up, and you specifically sort of, ask the question of, hey, how do I get additional treatment for leakage or incontinence? A lot of the times they can sort of refer you to specialists that might be close to you or myself, or tackle this problem, more head on. If you go to the website, also fixincontinence.com, which is, sponsored by Boston Scientific, which is the company that makes the sling and the sphincter. They also have like a search, for providers in your area toolbox, and you can put your zip code in and it'll show you sort of who is nearby that takes care of these kinds of problems.
If I'm 7 months post-surgery doing pelvic floor therapy, am I wasting my time?
No, especially, if you're continuing to improve, no, not at all. Now, if you're wearing 3 pads a day and every time you change them, you could wring them out and fill up a cup, well, then maybe. It might not get you, it might be at that point you could consider to have the discussions about the sling, sphincter, other options. But no, certainly, we would say sort of, 6 months is when most guys will get dry. There is additional sort of data that would suggest that guys that are sort of maybe wearing 1 pad a day just for protection, as they sort of go from 6 to 12 months, they can actually sort of get rid of that extra or that protective pad or go from 2 to 1. So they can have improvements between that 6 and 12-month mark. And this is based on sort of the studies and sort of how they define what incontinence is post-prostatectomy. And that's where you hear this number where most guys, about 90%, are going to be sort of socially dry, at 1 year. So there's definitely some improvement that can be gained, from the 6 to 12-month mark. So I wouldn't give up, but I would sort of have a, backup plan, particularly if the severity of leakage is significant.
Is there a relation between incontinence and sexual dysfunction?
No, not in general. They're 2 separate entities. They can certainly coexist. And I would say the sort of most common scenario where you see that is, both of these problems occur after, what we're talking about right now is prostate cancer, post-prostatectomy. You can have erectile dysfunction as well as stress incontinence or incontinence. A lot of guys that will have sort of sexual dysfunction or difficulty maintaining or sustaining erections, may still be able to participate in sexual activities. However, will have involuntary leakage right at the time of climax or orgasm. And that can sort of lead to further sexual dysfunction by virtue of having leakage at that sort of inopportune time. There's not a relationship. One does not beget the other, and one doesn't cause the other or make the other one worse. They're just sort of symptoms of the same problem. So the nerves that control erection are sort of around the prostate, just like the sphincter muscle is underneath the prostate. And these things just tend to be in the line of fire when it comes to surgery and are prone to injury.
Does hormonal therapy play a role?
No, they've looked at, whether or not androgen deprivation or hormone therapy post-prostatectomy is going to impact, the severity of leakage. And in general, it's not. The hormone axis is primarily controlling testosterone production. And while testosterone production can sort of help, with muscle mass and sort of strength in general, there's not really a clear association that, being on hormones is going to portend a worse prognosis or more leakage after, a given treatment. And so I would treat them as independent. It's noteworthy, but it's not going to be a significant, driver of this process.
Okay, thank you, Dr. Goldfarb.
Yeah, thanks everyone for coming out.
Thank you, everyone, for joining us. You will receive a follow-up email that includes the link to this webinar presentation. If you have more questions or would like more information or to make an appointment, our 26 offices are taking in-person appointments, and all of our physicians are also continuing to take telehealth appointments. So you can get more information at our website, chesapeakeurology.com/telehealth. You can also find the phone number there if you would like to call. So thank you so much, everyone, for joining us. Have a great evening.